Hello, and thank you for joining us on this session. My name is Dr. Kenneth Seidu. I work in Kolebu Teaching Hospital and currently the faculty secretary of this ORL faculty. I've been tasked to talk on head and neck lymphoma, which I'll gladly do for you. First of all, I'd like to thank God for saving grace to Christ. I'll also thank our faculty chairman, Prof. Ise, the course coordinator, Prof. Fashionla, the course facilitator, Prof. Alabi. And gladly say I have no conflict of interest to declare, but I would like to plead with you all that all the images cannot be used anywhere else because the patients or their relatives have not been contacted for their consent and used here purely for educational purposes. I'll start off by talking about this 15-year-old male we saw way back. And had a neck swelling of about 6 months, severe pain, sickling AS genotype. Otherwise, there was only significant findings, a low HG of 8.6, huge neck mass, and then a white cell count of 140, most of which, like you see, is neutrophil. So we were having challenges sending him to theater, one because of finances, and then intubation. It's 18. So we did an FNAC, and the report came as was an acute inflammatory smear. We'll talk about this further at the end of the presentation. So by way of introduction, our aerodigestic tract is abound with lymphoid tissue. And lymphoma happens to be the commonest non-epithelial tumor in the head and neck region. It is said to account for less than 5% of all malignancies in the head and neck. And 25% of systemic non-Hodgkin's lymphoma present in the head and neck region. Also, 8% of all FNACs done above the clavicle yield lymphoma. And fortunately or unfortunately, otolaryngologists are tasked by just where they work to be the most people likely to make the diagnosis. So what is lymphoma? Said shortly, it is a malignancy involving the lymph node. And there's a blurred line between lymphocytic leukemia and lymphoma. And this is because they both being hemopoietic cells can settle between the periphery and then the center, which is the bone marrow or blood. So if in the bone marrow there's a proliferation more than in the periphery, being the tissue, it's lymphocytic leukemia. And if it's in the tissue, it's what's the lymphoma. And because of the dual nature of these cells and other cells in the hemopoietic system, classification of this thing has been difficult until in the recent past. Immunohistochemistry, flow cytometry, cytogenetics, and molecular studies have given us a great strides into classifying these diseases and more or less making a more accurate diagnosis of the cause. Historically, Rappaport in 1966 made it the first more or less scientific classification based on the cytology, where it divided into small cells and large cells. Over the period of time, due to the changes and the knowledge acquired through the immunohistochemistry and other procedures and tests, this classification has gone through a lot of changes through the working formulation, through the scale and sample update, to the rare European American lymphoma group presentation. By then, in 1995, WHO refined the real system to include Hodgkin's lymphoma and other lymphocytic diseases. And currently, we are working with the 2016 WHO classification. And this classification basically puts together all lymphoproliferative disorders. So we have basically we have two main groups, the Hodgkin's lymphoma and then the non-Hodgkin's lymphoma. But the non-Hodgkin's lymphoma has 4 groups based on the cells in the system. B cell neoplasm, T cells, natural killer cells. And then we have the post-transplant and lymphoproliferative disorders, and the histiocytic and the dendritic cell neoplasm. So all these 4 have their subtypes, and that's shown on the next slide. See how populated this slide is. It tells you how many pathologies are there in this group. So we are on the left, we have the mature B cells. On the right, we have the mature T cell and the NK cells. And here we have on the left the post-transplant lymphoproliferative disorders, and then the right, the histiocytic dendritic cell neoplasm. So we are going to deal basically with the Hodgkin's and the non-Hodgkin's lymphomas. So what are the causes of these pathologies? Evidence from studies in same siblings, sex siblings, and then identical twins have shown a 10% increase or 10-fold increase in incidence in same-sex siblings and 100 times in identical twins. Aneuploidy in Hodgkin's lymphoma is present, and non-Hodgkin's lymphoma shows a deletion and translocation of the c-MYC in Beckett lymphoma and a BCL2 translocation in follicular lymphoma. Also, infectious agents like Epstein-Barr virus, the human immunodeficiency virus, H. pylori, HPLV, hepatitis, herpes viruses, and chlamydia, as well as Campylobacter jejuni, have all been shown to cause lymphoma. So chronic inflammatory conditions like Sjogren's syndrome or Hashimoto's disease, and then rheumatoid arthritis. All these have increased risk of causing lymphoma in patients who suffer them. Immunosuppressive medications given to patients who have had organ transplants, as well as farmers using all those herbicides and organophosphates, as well as welders and workers in the lumber industry, also are at risk of this particular condition. In the US, lymphomas are the 6th commonest cancer, 88% of which is non-Hodgkin's lymphoma. But internationally, in the Southeast Asia region, the natural killer T-cell lymphoma is on the increase, while in Africa, and in a particular sub-region, West Africa, Ghana and Nigeria are endemic for Beckett lymphoma. In these conditions, both Beckett and then the non-Hodgkin's lymphoma, the male to female ratio leans towards the male. There's more male preponderance. Mortality increases with age, and most people are in the 56 and 7 decades. Beckett lymphoma, 40 to 50% are pediatric, while in the adults it's usually in people with immunosuppression as in HIV. By way of presentation, they may present as nodal or extranodal condition. In Hodgkin's lymphoma, usually they are small, moderate, or medium rubbery lymph nodes, and they grow with time. However, non-Hodgkin's lymphoma can appear as a mass in the oropharynx, nose, or larynx. And then the natural killer or T-cell lymphomas usually are ulcerative and destructive lesions of the face, and even can affect the skin. And we've mentioned lymphoma in the thyroid. I have to mention here that these may also have constitutional symptoms, of which fever above 38 degrees, night sweat, and an unintended weight loss of more than 10% of the total body weight over 6 months is conditional in this three symptoms group to have it and then use it in your prognostic workup. The differences in Hodgkin's and non-Hodgkin's disorders are listed here. And most importantly, the Hodgkin's lymphoma is usually in groups of lymph nodes. Most popular are the cervical and then the spinal and para-aortic lymph nodes. Making them sometimes present as superior vena cava syndrome, while the non-Hodgkin's leans more in the periphery. Also, in the Hodgkin's, they are usually in continuity, so like contiguous. If you start from the negative posterior, the sternum, and so forth. But the non-Hodgkin's can be anywhere. They have in the liver, then only in the neck, or appear only in the neck or the abdominal and lymph nodes. Mesenteric nodes in the word and then the Waldeyer strains are rare for Hodgkin's, but are common in the non-Hodgkin's. And also extranodal involvement is uncommon in Hodgkin's, while extranodal is common in non-Hodgkin's. And instead that in Hodgkin's, sometimes the intake of alcohol leads to pain. So depending on where the disease is, then you have a presenting complaint. So we can see on this image a very edematous tongue, obviously telling you there is obstruction to the lymph drainage of the tongue, and then meaning the lesion is in the base of tongue or next to or tonsil. So this will be an indication of hypertrophic tonsil, and it presents with pain. If it's the nasopharynx, it will present with a cervical mass, nasal obstruction, conductive hearing loss. And I guess you know why all these things will happen, especially the conductive hearing loss. And also sore throat and then a foreign body sensation in the throat. Also, if a nasal cavity mass presented, then you have all nasal congestion, you can have epistaxis, you can have a fullness or even twisted deformity. You can also have local swelling in the mouth and pain, as well as a parotid mass, as we can see in this image. Other parts of the head and neck is not excluded. So a patient presenting with an eye symptoms or ophthalmos or ptosis, change in vision could be manifesting as lymphoma, as in this image where you can see on the CT scan, this lesion in the orbit on the right side. Yeah, on the right side, but on the left. Also, you can have primary thyroid presenting as rapidly enlarging thyroid with dysphagia as well as softness if the vocal cords are involved. So how do you make the diagnosis? We mentioned constitutional symptoms, which you will see in the history, you elicit in the history. You will also have lymphadenopathy. If there's extranodal diseases, you are likely to have a unilateral tonsillar hypertrophy. The extent of the lymphadenopathy could involve the liver and then the spleen, as well as the wider strain. It's not rare to have bone metastasis if it's systemic, as well as strain lesions, as in mycosis fungoides. By way of investigation, you want to do a full blood count and an ESR, which is expected to be raised. Your full blood count, you see in the differentials, as well as you notice all those changes in the blood chemistry. Liver function tests will show increase in lactate hydrogenase, LDH. And then you have all those serum protein and electrophoresis indicating the specific changes depending on the type of pathology. You mentioned HIV and hepatitis as etiologic factors, so yours is to exclude them. And it's important to do a pregnancy test because depending on the diagnosis, the treatment may be adverse to any pregnancy that is ongoing. Depending on the size of the disease, you may want to do lumbar puncture to exclude CNS involvement. Having elicited your history and suspecting this pathology, you'd want to do a chest X-ray, part of the staging process, a CT scan of the chest, abdomen, or in pelvis as part of the staging, and MRI and PET scan. Earlier, there was need to do laparotomy for staging, which now has become redundant, mainly because of available imaging techniques. In your diagnosis, you want to examine the patient and examine this patient. We do what we know best, do anterior rhinoscopy, otoscopy, examination of the oral cavity, oropharynx, larynx, and then the neck. So after doing these things, you might want to also employ flexible endoscopy, rhinoscopy if you have them or that's indicated for you to do that. Having done that, have a fair idea of what lesions you are dealing with. Most likely you have lymphadenopathy. And then if it's depending on your suspicion, then your examination will yield a lesion, let's say unilateral tonsillar hypertrophy. Then you want to do what? Do a diagnostic tonsillectomy. As much as we abhor lymph node biopsy, it's indicated when there's a high index of suspicion and you have excluded all you have excluded upper digestive tract malignancy, then you can go ahead and biopsy the lymph node and the clinical picture suggests either a Hodgkin's or a non-Hodgkin's lymphoma. If you find a mucosal lesion, you can then directly biopsy that. If the lesion is in the parotid, you can do a fine needle aspiration for cytology. And if the cytology comes as a non-lymphoid pathology, then you can go ahead and do a superficial parotidectomy as a definite procedure and as a more conclusive histopathology specimen. If, however, the fine needle aspiration comes as a lymphoid tissue, then you can go ahead and treat as such. If the mass is a cervical mass, then I have to say that here it is parotid. I'll advise not to do a two-cut biopsy because the two-cut biopsy can, and I've seen one, injure the facial nerve, and this patient ended up with a facial nerve palsy for our own indiscretion. So back to the cervical mass, you can't do a fine needle aspiration, and if having done the fine needle aspiration, you find lymphoid tissue, then for more accurate diagnosis, you would want to do an incisional biopsy. If and only if this will not lead to undue morbidity if an excision biopsy is done. So if an excision biopsy is possible in the neck, you rather do that. But if not, then you do an incisional biopsy. But then preferably you should have a posing section available to check whether it's on the table while the patient is still on the table, whether it's a lymphoid tissue or it's non-lymphoid. If it's lymphoid, then your diagnosis is made and you can go ahead and treat the patient as prescribed. But if it's non-lymphoid, then the right thing, like is teaching, is to do a neck dissection, and then get a more concrete histopathology, and as if you were treating a neck node of unknown primary. It's very important in managing this condition to take a good specimen. We've mentioned how you can get the biopsy done, but the specimen, if it is not taken well, might give you a false histological report and consequently lead to errors in our management and the patient's outcome. So the specimen has to be adequate, appropriately taken, that's adequate, and preferably not from a necrotic issue, but at the margins where you can get healthy and then pathologic tissue. And then, because the nodal architecture is important, it should be big enough so that we can have meaningful nodal architecture portrayed. And for us to be able to do immunohistosis and cytometric studies, which will complement our usual H&E pathology, it's preferred to submit your sample dry or in saline. The use of preservatives like formalin and others can lead to errors in this regard. So we'll discuss a few patients and how they presented. So this is a 67-year-old farmer with a good history of smoking, a 2-month history of a sore throat, and then another 2 months of submandibular and left cheek swelling. So the referring facility saw a oropharyngeal ulcerative lesion, and then a biopsy, did a punch biopsy. This however returned histopathology report of granulation tissue. So they referred to us, and I'm sure your guess will be as good as mine. So you go and do routine examination, and then you, with this patient coming in, you did oral cavity. You see a mass list in the left tonsil region, and then on the neck was what you describe as a thick mass, and also swelling the submandibular region. This imaging has indicated you can see is a lesion in the tonsillar region, and then swelling on the left side of the neck. I ever had this lesion also in the liver. So we sent him in for examination under anesthesia, and we did where we saw an specific lesion with ulceration in the left tonsil, base of tongue, and in the piriform fossa. This was biopsied 3 places, and 2 of them, the base of tongue and tonsil, returned diffuse large cell T-cell lymphoma, while the one in the piriform fossa just said an ulcer. So our diagnosis for him was a diffuse large B-cell lymphoma. So this picture we are seeing is what after his treatment, what he presented to us. So the swelling has reduced significantly, and he was discharged. This condition is that was seen in a 57-year-old logical anemia. He presented with nasal obstruction of 8 months, in similar period, and then he had a facial obstruction of 6 months. So coming to us, he also had temperature spikes akin to the T symptoms. So he had imaging which shows a mass filling with nasal cavity with destruction of anterior part of the septum and a bit of the skin. So he was also biopsied, and his histopathology returned NK, that's natural killer stroke T-cell lymphoma, which until recently was called the lethal midnight granuloma because of the natural history of this condition. So it is usually a lethal condition, but if you see it early, you can give the person a fairly good quality of life. Now, from what we've seen, what can be some of the differential diagnosis of lymphoma? So they can mimic inflammatory diseases like C-ANCA-positive granuloma, that is like Buchnell's granuloma, or what now is called allomatosis, polyangiitis, polyangiitis, and then in cocaine abuse, in sarcoid, and then systemic lupus erythematosus. Can also mimic infections like necrotizing fasciitis, and in our good invasive fungal infection, as well as other granulomatous diseases. We shouldn't lose sight of also the possibility of other lymphomas, and then squamous cell carcinoma or basal cell carcinoma. condition previously endemic in sub-region and then East Africa. It can come as also as sporadic or as a result of immunodeficiency-associated condition as in HIV, which is more common in adults. The peak incidence is in the 4 to 7-year group, and it's more male than female. Epstein-Barr virus is thought to be present in most of the Burkitt lymphoma cells, where they exhibit chromosomal translocation with an overexpression of the c-Myc oncogene. And this basically is the basis for the pathology and proliferation. Their sites are usually extranodal, mainly in the upper and lower. So, and then the orbit or the facial bone. This occasional 50% of cases. CNS involvement is usually common, and so is sometimes abdominal involvement. In adults, they usually have HIV positive. So how is this condition treated? As much as ENTs will do a lot of the work in diagnosing this condition, this treatment is mainly by the oncologist and hematologist. In Hodgkin's lymphomas, use these as adramycin, bromycin, dacarbazine, and then non-Hodgkin's lymphoma, you could use a combination depending on the type of disease, as well as you can use targeted therapy like rituximab, or most of the time add radiation to it. So remember this picture, and the smile tells you, or after treatment, there's a happy patient. Now back to the young man we presented at the beginning. So with all these challenges he had, couldn't save the young man because he died within days of the picture we saw. And as much as we had wanted to get a biopsy and ask for a postmortem, the patient didn't consent to postmortem. Naturally, the body disappeared from the morgue. So with these circumstances, not just on hindsight, it was thought to be a lymphoma. We missed the diagnosis for this patient. So what's the take-home message? Have a high index of suspicion as a cause of common complaints in the head and neck region. So anybody presenting with a head and neck ENT complaint, which doesn't, as much benign or usual as it may be, if you can't cross your teeth and dot your eyes, think about a lymphoma. And when you've thought about it, or for whatever reason you are taking a biopsy, always provide a pathologist adequate and representative tissue, avoiding areas of necrosis. And if in doubt, always also, especially when you've taken they've reported a histopathology and doesn't fit the diagnosis, request a review, preferably at the center with an interest in sinonasal pathology, or even at another center in another facility. Thank you very much, and these are my references. So, question.